Hello, welcome to the Visage Academy online training modules. My name is Dr Michael Aicken. First of all, thanks for choosing Visage Academy. You've got lots of options out there, so thanks a lot for choosing us. We've been told that there are several advantages to our course. I'll run through those briefly as by way of introduction to the course. One is that we offer a pragmatic approach. So we focus on things which I have found as a practitioner were particularly tricky to figure out for myself. And whenever I attended a training course myself back in the day, I found that some of the things taught in the course were a little bit too much in depth, and some things I would have preferred if they were in a little bit more depth. So that's what I've set out to tackle in setting up this course. So hopefully you'll agree by the end that that is the case. We have been told that we offer straightforward protocols. And that is, there are several protocols. The main one really is getting the patient ready for treatment. So a lot of that happens behind the scenes on our simulated clinics, which take place on both the foundation and the advanced courses. But there will be a section of this course where I will talk you through a consultation and show you everything that leads up to the point where we inject the patient. Other things that are important in terms of protocols will be our consent form, and later on I'll talk to you about the system that we use for that, and also our aftercare sheet, and you'll have access to that also as part of this course. Options for further support. Well, you have unlimited access to me by email, so if you have any questions after the course, feel free to email me through. You can also, if you would like, send me photographs of patients and I can give you feedback on those. So you'll have noticed that there is a link above this where you can download a PDF file with all slideshow. So hopefully you've got that in front of you now, and that is what I'm going to be referring to throughout these modules. The particular slides involved in each talk will be mentioned below each video. First of all, now we're going to talk about the Glogau wrinkle scale. So you'll see a slide with 4 faces on there. The first lady has no wrinkles. Then the lady beside her has wrinkles with movement. Then the lady down at the bottom left has wrinkles at rest. And then lastly we have a lady who has nothing but wrinkles. There are a few important points to recognize about this scale. First of all, it's important to realize that this is not a scale of how people age in terms of chronological age. This is a scale in terms of how the lines and wrinkles on their face change with age and increase with age. The lady there who has wrinkles on movement, in my opinion, she possibly looks, and the lady beside her who has no wrinkles, both of them to me potentially could look older than the lady who has wrinkles at rest, and yet in this scale they've been placed the other way around from that. Another important issue then is whenever you have patients coming to you and they may use the phrase "make me look 10 years younger," they may ask you to do that. It's important to recognize that whilst you hopefully will be able to make them look more attractive and pretty and possibly younger, the main job that you have is to reduce their wrinkles. So I would suggest that you focus on that. Certainly you discuss the psychological issues involved and discuss the reasoning as to why they want this done. But your main focus and your main promise to them is that you will reduce the wrinkles on their face. I would suggest you don't promise to make them look any particular number of years younger. The next slide I want to discuss is the aging face. You can see there is a picture of a younger face and a picture of an older face, and it's really looking at the lower half of the face. This is because a lot of the aging happens in that area, and actually a lot of the aging happens in that area can be treated with dermal filler. The upper face by and large is mostly treated by Botox, whereas the lower part of the face is mostly treated by filler, although there are exceptions to both of those. So let's talk about some of the features. Whenever you look at these two faces, it's very obvious which is the younger, which is the older. But let's zero in on some of the exact features. Loss of lip projection, so this means from the side profile. When someone's side on, the lips will flatten down with age. Along with that, the white of the lip will extend downwards and the pink of the lip will subsequently thin. Along with that, the philtrum, these two lines here, will flatten down. Cupid's bow, well, part of the pink of the lip, that will flatten and thin also. Dermal and subcutaneous atrophy, that's a bit more complex to explain. Basically, the subcutaneous tissue, so every bit of tissue below the skin, it starts to thin, which means that you can see the patterns made by the muscles underneath more easily. So the fat goes away and you start to see these little vertical lines develop. So they're sometimes called smoker's lines, they're sometimes called lipstick lines. The reason they get called lipstick lines is because when the lady applies lipstick, the lipstick can bleed into these little lines. The reason they're called smoker's lines is because whenever people smoke, they tend to pout and tighten their lips around the cigarette. And the final point on that slide about the aging face is atrophy of the orbicularis oris. What that means is the orbicularis oris around the mouth, it starts to weaken, allowing the depressor oris angularis muscles, which attach to the corner of the mouth, down onto the mandible. It allows them to pull down the mouth corners. So that's why you tend to get the sad face with age. Skin anatomy. We're not going to go into a lot of detail on skin anatomy, but this slide is here for one important purpose. That is that in the old days, when Botox was first being used for cosmetic purposes, it was understood that Botox worked on the neuromuscular junction, and we still understand that, and it's still correct. But we used to think that you had to inject the Botox right the way down through all of the skin organelles, the veins, the capillaries, the arterioles, the nerves, the glands, all of those things. We used to think the needle had to go through all of those to get down to the muscle, which is the bottom layer on that diagram. What we know now is that actually if we just get the Botox injected below the waterproof surface of the skin, so into the dermis, the Botox will find its way down to the muscle and take effect there. What that means is we don't have the need to risk the side effects associated with running the gauntlet, putting the needle all the way down through those skin organelles. We can put the Botox just safely below the surface of the skin, and it will find its way down and have the same effect on the muscle as it would if it was injected directly into the muscle. In fact, because there's probably going to be less bleeding doing it that way, the Botox is less likely to be diluted and will therefore have be more effective injected in that way. So we can expect when we give our injections of Botox, usually we will see little blebs, little bumps where we've given the injections, and that's just the fluid that's left behind when we inject in the Botox. And we reassure our patients that that will go away usually within about 30 minutes from the time of injection. So how do Botox and fillers work? Well, you're going to learn a bit of detail about that throughout the day, but what's probably more important is for you to know a kind of one-liner answer whenever your patients ask you about Botox and fillers. They're more likely to ask you which is best. They might ask you in general, but they're probably going to mean for one particular part of the face. So I would suggest you have an idea as to what your one-line answer is. So I would say to them, Botox is a medicine and it's a toxin which paralyzes muscle. I probably wouldn't use the word paralyze. I'd probably say freezes or weakens muscle or relaxes muscle. So it's best used for lines that are worse on movement. Whereas filler, it's easier to understand. It's just the same almost as filling a crack in the wall. It's used to fill lines. That's a simplified version. Obviously, you're going to receive a lot more training than just those two sentences, but that's a good starting point when you're discussing with patients who have never had Botox or filler before, because a lot of people won't know that they're two completely separate treatments. You'll see in the slideshow there we have a diagram of a botulinum toxin type A molecule. It's not so important that you know how to draw that or how to recognize it on paper, but what is probably more important is the next slide, which has some photographs of the packaging of the different brands of botulinum toxin type A that are out there. So we can see Azelure is there. It is the same chemically as Dysport. These are still botulinum toxin type A's, but they're not Botox. Botox being a brand name, which is also on that slide. It's important to note that all of these toxins are equally effective. There have been small studies only comparing them, and generally speaking, the findings of these studies balance each other out. So nobody really has proven that any one is any better than the other. It's worth noting that each of them has a number of units that they have within their vial, but it's important for you to notice, or for you to be aware of, the fact that the units are not the same whenever you move between the different brands. Roughly speaking, 125 units of Azelure is equivalent to 50 units of Botox. So today, in our practical sessions and on our course, the face-to-face part of our course, we'll be focusing on one particular brand and getting you familiar with that one. After you have become familiar with that, you're free to do whatever you want when you finish the course. You can change over for whatever reason you choose. But it's best for us on the course to stick with one so that you can get really familiar with that. Bit of the history of Botox. Back in the 70s, there was a psychiatrist carrying out a study of patients who had a facial tic, so twitching one side of the face around the eye. The hypothesis was that if they injected those patients around the eye, there would be less of a facial tic present. And it worked. But the important part of the story is the legend part of the story that wasn't recorded in the scientific research. It was the story that was maybe told afterwards. The story is that the psychiatrist who carried out the research found that she had a queue of women outside her office after the study had finished, and each of them asked her the same question: could you please inject the other side of my face with that treatment? So she happened to tell her husband, who was a dermatologist, and together they realized that potentially there was some money to be made from the manufacture of this product, which then became known as Botox. Within about 10 years of that, there was an FDA approval, so that's the American approval for food and drugs. And since then, not very much has changed with the Botox module. Not very much has changed with the Botox molecule. There are some other brands which we've already discussed, but the actual original Botox made by Allergan has remained the same, apart from some packaging changes. So current UK Botox approvals. There are a list of approvals on the slide, but I'll just point out a few. Some big muscles can be injected with Botox. So if a child has cerebral palsy or an adult has had a stroke, they may have a contracture. So this is where a large muscle, such as the bicep, will pull tight, and because of a thing called spasticity, that contracture can cause pain. So injecting large amounts of Botox into that large muscle, although it does not restore function, it can relax the muscle and reduce pain. So Botox can be used for those things. Those are not treatments that we'll be covering on the course, but it's just important for you to be aware that other medical specialists will use Botox for different purposes other than cosmetic purposes. Something that we will be covering on this course will be hyperhidrosis of the axilla. Some practitioners may not wish to perform this treatment, such as dentists who might feel that anything below the neck is out with their remit as dentists. That's fine. You can ignore the module if you prefer, but I think the insurance companies are happy for us to do it. So you can chat with your insurance company and decide with them whether or not it's something that you should offer patients. It certainly is a very easy treatment, and there are not many side effects that would put patients off, in my experience. Other clinical conditions, well, there are a list of different, another list of things on the slideshow. Migraines and tension headaches. Every now and again, these do the rounds in the media, where a celebrity will come forward and say, I was saved from migraines by Botox injections. It is true now that on the NHS it is possible to get treatment of migraines with Botox. It's not something I offer specifically for migraines, but it's worth noting that part of that treatment is treatment of the frown line area, which we certainly will be covering on the course. And in addition to treating the frown line area, the official treatment for migraines will also inject parts of the scalp, the shoulder and the neck